Can everyone see my screen?
Yes.
Yes, please go ahead.
Okay. Like I said, good afternoon, good morning. Depends where you are. Thanks for joining again. We're going to have this express section today. We say thank you. So we're going to start first by our housekeeping rules. I think you can view them clearly. We're going to be at much time conscious. We're not going to eat all of the time today. That is, we're maximum going to go hour 20 minutes or hour between that. Depends on the question you will have. We will have two Q&A sections. So you have the time to ask. Our objective of today is to understand essential medicine list, and then what can we do to improve it, and also who do we approach. So we will look at our housekeeping. We say kindly mute your mic while you are not speaking. Turn off your video in order for us to have, because people may not have good data. Please ask your question in the chat box, or you can raise your hand and then you will be recognized. You may ask question in the chat box at any time. To ask question by talking, you will need to raise your hand. When and only when you are invited to speak, please remember that to unmute and turn off your video. This webinar is recorded, and then it will also be shared with all those participants here. And you can also find it on Empowerment School channel. The slides will also be shared with participants. Let me know if I'm speaking faster, or I'm talking slower, or you cannot hear me. Thank you. So thank you once again. Welcome to this express section. So we look at what the objective of the webinar. The main objective of the webinar is to give you the chance to ask questions and do you get answer from an expert. Today, yes, I'm a keynote speaker, but I'm not the full-time expert. You will have people that will give feedback. We have Priya, we have a Prof. Andy also in the background that will be listening to your questions. In this presentation, I will speak and I will summarize the module, which is module 2 that you already know of, and then I will entertain your questions, and then we indicate the measure we can take to improve when it comes to the essential medicine list. Here I talk about timing. That is introduction. I think most of us have already introduced ourselves in the chat room. You all heard my name. You heard Priya, you heard Andy talking, and then some other colleagues that participate here today also talk about, introduce themselves. So we'll be discussing what the key point of the module 2 is the essential medicine concept. What concept do we use? Because we noticed that everybody have EML, but unfortunately not being used. Then we entertain question for 10 minutes, and then we come back. We have the impact of the essential medicine concept and how can we implement it or improve it. Then we have our second Q&A. So welcome once more to module 2. They talk about public health commodities. I think we all understand what the meaning of first. We look at essential, what the word essential means. Essential, we're talking about essential medicine. Majority of us participants here today know that we have essential medicine list in our country, and that essential medicine list take care of the everyday illness in that country. I'm from Liberia. I've worked in the health sector. I supported the Global Fund program. I see one of our participants was chatting to me directly. She also supporting the Global Fund program, which would turn over to another organization when I used to work for Population Services International. And then how is the essential medicine list is being selected? What criteria is being set, right? The use of international non-proprietary, which is the generic names. And we talk about the essential medicine list in context, the list of registered medicine. We talk about the formulary manuals, the treatment, the guidelines, and we also talk about the therapeutic classification system, the operating selection, and how it works. Key point, most often we talk about theories. People just say, oh yeah, there's a EML, essential medicine list. Are they really being practical? Are we practical with the listing? So that's why we're here for today. All of you are experts when it comes to this. We want to know whether these things have been practicalized. So take a key point here, look at what the points are. We talk about the fundamental principle. We talk about how it's being established, what year, and how it's being utilized. Where is the implementation? Is it being implemented in what countries? Is it being implemented in the regional warehouse, the regional drug center, the central drug center, the villages, the counties, or the province? It depends which country you're in. So it is clear those are things we'll be discussing today, and your inputs, your questions are very essential. How do we know it works? Are we having challenges? Is it working? Those are questions we'll be asking today. We're looking at evidence. We're looking at whether the government participating, whether the doctors, the nurses are into it. What is it not implemented? I can tell you that a lot is not being implemented. People have the essential medicine list. They're just looking at it. Because I give an example. A lot of health practitioners want new drugs. A doctor will tell you he wants the latest malaria treatment. He don't want to go back to the old. Apparently, the new malaria treatment is not being amended with the EML. So you have to look at that. But before we go further, we have to understand that EML is just not being country originated. EML comes from what? WHO, who is the governing body when it comes to medicine. WHO have a full listing of EML, and then it's being categorized into country levels. So we should put that at the back of our head, is that you're not just establishing an EML from your country. Be familiar with what the concept. We own what can we do about it. These are points we'll be talking about. Be familiar with the evidence that they work. Understand the full implication of their implementation. Understand the pros and cons. We'll come to that. Be prepared to advocate for the implementation. So today we'll be looking at two words. I did mention one. We talk about advocate. Advocacy and what? Explanation. You should be able to explain and advocate for it to work, right? Be prepared to rebuke the propaganda and false information from manufacturer. Be prepared to suggest practical way in which they can be implemented. Start measuring the KPIs, which will show their very positive impact and economic benefits. Basic concept, I'm not going to dive into reading totally. What we're going to do is that the basic concept here is about the essential medicine is that every country, time will come, you ask me a question or I will ask you a question, that is, has limited resources. So what can we put together in terms of essential medicine? Should we prioritize malaria medication? Should we prioritize medicine for HIV? Should we prioritize medicine for tuberculosis? So those are things you should be looking at. Are they part of the essential medicine list? Right? And then we should look at the global pharmaceutical market. Are they available? What are the implications? The rare, the orphan disease, right? We should be looking at that. If we look at these things and then we compare it to our essential medicine list, we will have something better. Fundamental concept. EML is not static, not at all. These are lists that it changes on a daily or quarterly because it has to be reviewed. There are new diseases, there are new treatment guidelines. So definitely our EML all the time have to be reviewed, and there should be amendment made to it. Okay. Non-communicable diseases have traditionally not been seen as major priority in low-income countries. I give you an example. Liberia is a low-income country, and non-communicable disease have become an issue to others, the NCDs. So we prioritizing malaria. We're not prioritizing somebody having whooping coughs. We're not prioritizing some kids in the village that have not been vaccinated. So we should take key attention to these. The concept, fundamental content, evidence-based. I will look at governance. Are we going to our parliamentarians? Are we going to our lawmakers to convince them the purpose of essential medicine list? I give an example in my country. Our health budget is lower than the Ministry of Finance and Planning budget. So how can we convince our lawmakers to increase the health budget? Because if the health budget is low, definitely we're not going to have good money for our EML, and the EML will not be active. So I will urge all participants here today, you should be ready to advocate you should be ready to explain. Go to the what? The ministers. Go to the lawmakers. Make them to understand the purpose of the essential medicine list. If we don't do these things, the essential medicine list become theoretical. It can never be practical because they won't understand. Explanation and advocacy should be our key drivers in order to improve our EML practically. These are all examples that talk about what you can prioritize in terms of the EML listing, right? You have the DALY, the disability and adjusted life years, and you also have the quality adjusted life years. A parliamentarian will not understand this, a medical practitioner or somebody who understands medicine go and explain this to him. So people on this panel expert section today need to understand that when we explain to people, when they understand what the meaning of the EML, they will be able to make it practical. It's not a one-person thing. It's a full coordination that every hands have to be on deck to get it moving. Sorry, if you can see the slide too clear, let me know. So these are like examples of showing disease or injuries and also showing the talent and also to millions. The number you see there in percentage and millions. So we talk about HIV, what have been spent. The data come from the WHO. So all these slides will be shared with you. And then it depends countries. Liberia will give priority to a different EML listing. Maybe Guinea will give another difference. The United States will have a different EML, and another country in Europe will have a different EML. So it depends on what is being prioritized by the country. So you should be able to understand these things. Evidence which medicine works. There could be a disease in a tropical country that is not active in another country. So you have to know what works in your country. Like I remember maybe a couple of years back in my country, we were still using chloroquine. Now we've gone to the Coritrin or the ACT. So another country may not be using that particular medication now. So you have to understand which one of the medicine work for your country to be able to include it into your EML listing. And medicine is all about money. You cannot have an EML list just lying down. You have to procure the drugs. You have to talk to your government, like I said. You have to advocate. You have to explain. Then you'll be able to know what you can spend for malaria, what you can be able to spend for vaccine for kids, and what you can be able to spend for vaccine just in case there's a pandemic. We had the issue of COVID. Richer countries have to jump in and be able to serve poorer countries in the world to be able to supply vaccine around the world. So you have to know costing. You have to calculate. You have to explain to the people putting in the money, their charity. They have to know what the reason of putting in $10 million for jobs in your annual budget for your country. If you don't do these things, nobody gonna pick them up. So that's why we say you should advocate, you should explain, and make sure that your explanation have a strong backing. This continuation of the costing. There's a diagram that shows cost effective of 123 preventive interventions. These preventive interventions might have been on a listing of a country EML. And you see the costing that shows different places. You got 10,000 to 50,000 on number affected 31. You get 20 on the other side that shows 0 to 10,000. And it showed that what were being spent, where it came from, so if you're presenting this to the authority, these are evidence-based issues. It could be another country, but you could use it for your country. Before I go forward, maybe you can put in the chat room that are you using the EML in your country? Maybe just say yes and then mention your country, then we will know. Sorry, this slide is a little bit small. This background of what we talk about the cost effective, the ratio. You have the slide in detail. I don't think you're seeing this too clear. It talk about the diarrhea, HIV, details. I think some people are student and some people are graduate. They understood what we talk about, the pharmacopoeia, the pharmacoeconomic situation. Should you add into what? The EML? EML is just not one person thing, like I said. It's something, it's a combined effort. When there's a new drugs, you want to know whether it should be added into the EML listing. It should be approved. What are the decision based? Quality adjusted of life year. So you have to understand what need to go there and what need to be removed. Maybe there's a drugs in the EML listing that is no longer linear in your country. So if that drugs is not needed, no need to maintain it. So like the UK, as an example, you see they say such decisions are taken by what? The National Committee called NICE. So NICE will review documents and review new drugs and say, okay, this drugs based upon the reference, the source, the batch number, and based upon the disease at the time, it can be included in the EML. So like my country, I can tell you we're trying, but we haven't done extremely well in terms of practice when it comes to our EML listing. So I know other countries in the world may have that. The NIC is the National Institute for Health and Care Excellence. What are the key points we'll be looking at here today? PSM rather. Do not make these medicine selection decisions. Then us as logisticians, as supply chain people, we get involved with what? The medical people. You must sometimes have what? Input. An example could be the supply chain handle a vaccine, like Pfizer and biotech, which require storage at 70 degrees, not better charge or different vaccine. So logistician, we follow these rules that make sure, okay, where we storing the drugs, it's going to be cool, it's going to be fine. But in terms of including drugs into the EML, it's not our duty. We just give our comment and say, okay, you're including these drugs, this is where you have to store it, this is the degree you need to store it at. It may appear very complex, but the key point is that hard evidence is being used to aid medicine selection. That's truth. There's a hard evidence. You need people with the expertise to do it. It is not necessary that you try to make all the calculation and comparison only to facilitate the work of a committee, drugs and therapeutic committee, which will consider a published evidence to make a decision. For many countries, they can just refer to WHO model essential drugs list for guidance. Liberia is one of the countries which has already undertaken all these comparisons. It is as necessary that you understand the process and are prepared to implement the decision. If I'm speaking fast, let me know. So we have the next 10 minutes for Q&A. Priya, you will help me because I won't see hands unless I go back. You will help me of those who putting their hands up to ask questions.
Yes, so I would request you all, if you have any questions related to the topic, please raise your hands, or you can just unmute your mic and you can go for it.
Okay, we have one in the box already from Felix. How does the EML team work with the NRA?
Okay.
So I guess that's the National Regulatory Authority. How does the Essential Medicine team work with the National Regulatory Authority?
Okay, that's good. Okay, Felix, thanks for your questions. So like we said, there is always a committee set up. The EML team, the regulatory body have to first confirm whether this drug is from a reliable source, whether it's being produced. It's not a fake drugs, because like you heard, we say what? You should avoid propaganda of bad drugs, bad information. So the NRA is the regulator. They have to first okay whatever drugs that comes to the country. So the EML teams must work with the NRA. I hope that answers your questions.
Okay, if you want to ask a question, just unmute and you can just speak.
Hello, good afternoon or good morning.
Yeah, go ahead, Christian.
Yeah, please. So I want to first of all to thank the host for the quality of the presentation. It was very instructive for us. So I had an indirect question on what do you think could be the interaction between EML team and a quantification committee where it exists? What I mean is, can we have a quantification committee working while an EML list is not made available on a regular basis? And in this situation, how can the quantification committee handle their work, their job?
Sir, if you can repeat your question, I didn't get it too clear.
Okay, I'll perhaps try then. How can the quantification committee work with the essential medicine list committee?
Thank you. So, like before we got you with this session, we use an example here for the National Institute for Health and Co-Excellence. So the national in the UK, it could depend your country. Like in my country, which is Liberia, Phyllis mentioned the NRA. So our one is like National Health Regulatory Authority. So it's NHRA. So the NHRA work with what we call the NDS or the National Drug Service, because the quantification comes from the National Drug Service. They project how many drugs is needed for the country. So the NRA first have to authorize all, NHR have to authorize all drugs coming to the country. So the quantification committee and the EML, they have to work together. Usually the EML should be sitting in the purview of the NDS, but then EML is being established. The main key holder of the ML is the Ministry of Health of a country, and NDS also falls under the Ministry of Health, right? So there is no way that one person would do a work. And your question, if I got it clear, that maybe there is no EML in that country. How can the quantification committee work in order to make sure we have drugs in the country, right?
That's the question. Yeah, that's it.
Good. So there is always authority given to a committee. I know there can be a steering committee to spearhead something in terms of emergency, right? And then there could be projects. But most countries nowadays do have an EML listing. Our issue with the EML is that it's being theoretical, it's not being practical. So we want to know, how can we make it practical? What can we do to make the EML a practical listing? So the quantification always work with the EML. I know quantification committee will do a design, but at the end of the day, we will have an EML established in place.
Okay, I'll perhaps add to that. Basically, you should only be quantifying medicines which are on the EML. If they're not on the EML, you should not be trying to buy them. You should not be quantifying them. That's the key purpose of the EML. So the EML is the starting point. If the medicine is on the list, then we quantify it and eventually buy it. If it's not on the list, we don't. That's the fundamental point of the EML.
Okay.
Okay, we have another one.
Thank you, Andy.
Yeah. Does WHO have an oversight function of an EML of a country? Sumo, do you want to take that? Does WHO have any oversight of the EML in Liberia?
No, so I would take that, Andy.
Yeah.
So I answer her directly. That was Kiabe. I think she's a Liberian or something of a sit with. So WHO is the global EML listing. Every country have their own EML based on the WHO. WHO don't have an oversight function of an EML of any country. They share that listing with you. WHO will have a list for the world. What if the drugs, medication that is on that listing is not being needed for Liberia? That's why they say the list is not static. It's always amended. You delete, you add. So WHO don't have an oversight of a country EML. Gambia, okay, she's from West Africa, good.
Okay, good, all right. What I will say is that WHO do monitor the EML.
Yes.
They don't have an oversight, they have no authority to tell you what to do, and they don't try to. But they do monitor how many countries have an EML and how many medicines you have on the list. And that's published, and you can find it on the WHO site, and you can compare your country with others.
Thank you, Andy. We still got 4 minutes to questions. You can still ask your question. Still got 4 minutes.
Yes, one more from my end, please. About the standard treatment guidelines. Who influence, who is it standard treatment guideline influencing EML, or EML influencing standard treatment guideline? What is the right order of, what's the right order? Sorry.
Andy, can you help on that?
Yes, okay. The right order is that you do both together. So the Drug and Therapeutic Committee has oversight on the standard treatment guidelines. So every drug in the standard treatment guidelines should appear on the EML. And every drug on the EML should appear in the standard treatment guidelines. Unfortunately, in most countries, the two don't work together. And you get the standard treatment guidelines, which then are different to the EML. But in the ideal world, you work together and you do both together.
So your question answer. So we're wrapping up for our question section. Is there any other questions? Okay, I consider that there's no question. So we proceed to the second part of our express section. Thank you for all your questions. Keep asking them. If some pop up, go in the chat room, ask your question. They will be answered. So we move to our second part. We talk about what is the impact of this approach. And what approach we're talking about? The approach of EML. Some people may now receive optimal treatment. That is true, as mentioned in the first session. Like I said, I won't do much of reading. I think we can see the screen, and then the slide will be shared with people. And we want to, like we've done this in the Q&A, we're making this an interactive one. Your questions should be asked. We should be able to answer them. That's why you have the expert here. What is the impact of the approach that we'll be looking at? Like Andy mentioned, the Drugs and Therapeutic Committee determined it is not cost effective and would not add a tool, what? The EML. This goes to our brother who asked that question. I think you get more detail on this from here. What is the alternative? Are we providing medicine? We're looking at the cost per patient. If you go to the WHO website, or if you read on HIV and AIDS, and you get to find out how much it costs to treat one patient per day, or per month, or per year, how many authority in your country understand that. Those are things you should be looking at. Are these drugs essential for the country? Should they be included onto the essential medicine list? I think if I remember the last time I checked, to treat the HIV patient per month is pretty close to, I think, $80 or $84 per month. So if you have 200 HIV patients, do the math. Imagine what that takes. Do our lawmaker understand this? Let's move on with our keywords again. Advocate, explain. If you don't do these things, nobody understands you. I come from a developing country, Liberia. I should be able to go to my pro tem. I should be able to speak to the president. I should be able to speak to the minister to tell him that we have 500 patients that lay on ARV, and each patient requires $100 per month in terms of treatment. What about new medicine? What do we do? Do we get some new medicine on the listing? No, there is a committee. Thank you. Somebody mentioned the NRA from their country. My country is NHRA, National Health Regulatory Authority. They need to confirm if this drug is good. Most countries have a what? Waiver scheme, whereby if the medicine has received approval, good. Emergency approval from who? WHO. Andy said that. WHO is the monitoring arm. They have a big list of EML, but you have the NEML, which include your National Essential Medicine list. COVID vaccine, are they on your country EML list? Maybe somebody could answer that question for me, or somebody could tell me, yes, we have included COVID vaccine on our EML list. Because COVID is still around, people are still taking vaccine. Manufacturer, that's what we say. There's no way a drug will come into your country when it's not being approved. Your regulatory arm need to approve it. But hey, in developing country, some drugs come to the country that's not being approved. I'm from West Africa, like Kebe, she's from Gambia, she's also from West Africa. We face serious problem with fake drugs. So that's why the NRA need to make sure, and Andy said, if a drug is not on the listing, the EML listing, no need to buy it because it's not being approved. I just read this portion. It says 60% of prescription drugs are and 80% of over-the-counter drugs were found to be what? Misleading or false. Somebody tell you good thing, you see on TV, the drugs look good. But unfortunately, they're not the right information they're giving you. There were cases of blatant lying, but these have truth from more than half of our analysis. These links in the slide will give you more detail when you go through them. What's my role? We're all sitting here today. If I look here, we're 34 participants, excluding Priya and maybe Andy. So what's my role? What can I do? Are we all aware of a national essential medicine list in our country? Maybe everybody could put their hands on and say, yes, I do. Somebody who on this express session today does not know about a national essential list. Please, you need to know about it. Ask your health authorities. You need to see it. Maybe one day you'll be passing by to a pharmacy and then you see your drugs. It's not on the list. It's all right to ask. How the national essential medicine list handled in public procurement of medicine? Those are questions you should ask yourself, right? You said you've been procuring drugs. How is it helping? Are you receiving, storing, distributing medicine which are not in the national essential medicine list? WHO new approval. That's what we're saying. People bring drugs into their country. It's not approved. New medicine be approved by WHO. We might not waive declaration. Your role in supporting drugs and therapeutic community medicine selection and possible input you could make. Like Andy said, let's go and meet our parliamentarian and discuss the national essential medicine list with them. Let's advocate for more money to buy drugs for the country. Because if we do these things, then more people will live. We will get rid of a lot of diseases. We talk about drugs and therapeutic committee, an example of PSM import. I'm now a medical practitioner. I fall on a PSM, right? That's the supply chain component. You notice very poor condition of capsule being dispensed to patient because they have been sitting a long time in an open bulk bottle. You could recommend changes, formulating blaster packs instead of what? Bulk bottles of towels and capsules. They stay there in heat, they're not even being stored to the right place. So PSM, this is where we come in. Then we say, okay, this drug, according to the manufacturer, it should be stored at this degree. You're not storing it at that degree. So it becomes a problem. So it's not a one-person thing. That's why we ask the question, what can I do? This example will help you tomorrow. Let's look at the HIV component. You notice many clinics do not have adequate refrigeration. I work in the southeastern part of Liberia. There's no electricity. You take 3 to 4, 5 days to transport a vaccine to Grand Cru because of viral condition. What are you doing? Are you putting the vaccine into the red cool box? What measure could you take? Okay, there's no electricity. Can we use solar power to be able to store these drugs? Come up with a recommendation. Let your authority know, because you need solution. People are living, they must survive, right? Does generic name really matter? We have to look at that. You will have details on this link. They say prescribing by generic pharmaceutical name should be strongly recommended or encouraged. Yes. You're just not going to find one just because it's carrying the name ACT. What's the generic name of that medication? You need to understand all of that. You need to know what approved name we have, whether it's from France or whether it's from the UK, whether it's from America, whether it's somewhere being produced in Africa. Let's make sure we're following the generic name of these drugs. I will read a small portion in here that talk about legislation, right? It's a generic, non-therapeutic name are intended for use in pharmacopoeia, labeling, product information, advertising, and other promotional material. Drug regulation and scientific literature as a basis for product name. Example, for generic, their use of normally required by national or, in the case of European community, by international legislation. If they're not okay, you don't need to use them. And they come up with an example that the ban, like the DCF, the JAN, the USAN, the INN. We need to understand these things in order to move forward. Make sure our EML is in tight. Overcoming brand names. Like we said, generic name is very essential. You could get the same ACT from China and get the same ACT from the UK. It depends on the brand names. Whether is it essential to us? There's a suggested evidence that the doctor in Karachi setting recommendation expensive brand name if they offer incentive. Yes. Some brand names, some people, it depends the location. In public hospital in China, 370 million could be saved from switching only full medicine, saving an average of 65%. Strategy to promote generic uptake, such as generic substitution by pharmacists and increasing confidence in generic by professional and public, should be included in national medicine policy. So are we saying we should include that into our EML as well? Yes. WHO, we look at sole brand name and generic drugs, always indicated no. Some brand name product might be considered superior. Well, maybe in my country, I give you an example. If you take a Liberian and say, okay, this is drugs from America or Great Britain, he say yes. And this is one from China, he will say no, you don't want the one from China. So we have to understand these things. That's why we have our what? NRA, like one of our participants said, my country is NHRA. Let's look at it. What are they approving for us? Somebody say Bayer. Bayer, who is a brand name from where? In America. It's on aspirin drugs. Bayer is a company. Maybe you prefer to take only Bayer. Or you want to go from France. Like you have the Bavar, the Bartec. Which one of the vaccine you want to take? We have the issue of the vaccine of COVID. People feel they can only do AstraZeneca. Somebody said, no, I want the one from America, Johnson & Johnson. So it shows the parity, but then at the end of the day, our main focus should be what? Our generic names of drugs. Somebody asked about WHO, EML, and what they are oversight. They have oversight. No, and they have answered that question for us. They monitor our EML, they monitor our EML for us. That is clear for everyone. They want to know what drugs you're buying, what are the new drugs being authorized by WHO, and what is being authorized by your regulatory authority as well. So we should understand that. Let's talk about what the variation between countries. I was talking about my country, right? Somebody in another country talk about just the NRA. I talk about the Health Regulatory Authority. So it shows here, this is, we've identified 137 national lists of essential medicine that collectively include 268 unique medicine. Each national list contains between 44 to 983 medicine. Maiden is 310. So you see the difference there. Maybe my country don't even have 50 because I'm from a small country with less than 5 million people. Maybe another country we carry like 100 million people may have up to 800 on the essential medicine list. So these are things we need to look at. We look at the comparison. What diseases in that country that is not in my country? So you can't, if that was the case, then the WHO would have had oversight. But they cannot control that because what is happening in Liberia is different thing happening in Gambia. Or what is happening in the UK is another thing happening. Like we in Africa, we don't really experience like this flu. America give flu vaccine like every season, right? Liberia, my country, we don't do flu vaccine. So you will not put flu vaccine onto my essential medicine list for me, no. So those are the points. So you look at the comparison and see how it works. The links are there for more details. This is just the map to show as per our discussion we had. You see the many countries are not fully in the fast guidance of WHO. They mentioned the numbers. If we did go back to the slide, say 137. Think of how many countries in the world. Only 137 WHO can account for in that year that have an essential medicine list. So the concept, that's why we're pushing the concept today. Somebody said they were asking the quantification. Is your country still having, you don't have an EML list, then they need to have one. What does this mean? The main finding of the report revealed that WHO model EML has evolved and expanded since its inception in 1977, almost doubling the size. That means people are following, but it's being theoretical. We want to make the list practical now. We want to make the list practical. From 1977, countries have established an EML, but it is working? No, that's why we need to push. The absolute and relative number of non-chronic disease and selected chronic disease included various widely across country EML in comparison to WHO model. Colleagues, can you kindly mute your mic, please? The absolute and relative number of non-chronic disease and selected chronic disease include various widely across countries EML in comparison to WHO model. That means people have the WHO, but they've made their own listing. Depends on the disease that you have. You can't use WHO listing fully, right? So great idea, but own it if implemented. I want you to look at that work cleanly. It's a great idea of having an EML, but are we implementing it? And we're in the section today to know what should we implement and what do we do in order for the listing to be implemented. And like I said, we need to advocate. We need to form committees. We need to explain to our leadership that this is the essence of the listing, and this is what I would do if we get more money to it and make this listing a practical one. ATC. We all understand the meaning of that. One of the drugs maybe in Africa is mainly being used, the defined dialysis dose, and mostly on the malaria because Africa is a tropical region, most of the malaria, the mosquito bites. So ATC, that's why it's something common in our country, but it's from different countries. So is ATC part of your EML listing in your country? I can tell you, yes, Liberia, it is part of mine because malaria is a common disease in my country. The UK or America, maybe malaria may not be a common disease there. So they may not include that for now onto that listing. ATC is used to compare different medicine. The medicine selection, drugs, and therapeutic committee, they always make sure to do that, right? PSM does not decide ATC classification, but it also have medicine lists formulary and labels, which include the ATC. So we talk about the levels, the various levels in the ATC. The system has 14 main anatomical or pharmacological groups. First level, the ATC first level shows in the figures. We're not going into details, but it shows the tract metabolism, the blood and blood forming organs, cardiovascular system, the dermatological system, and it gave a full listing to us, up to what? 5 levels. It talk about chemical substance, the third and fourth level as well. So this are common international medicine product guideline and price. So you want to buy medicine, whether you buy in dose or you buy in capsule, you buy in tablets. This example here with the link can give you more guidance with prices. It depends on which country you're from. Maybe it will include all attachment, but these give you exactly the price of the drugs that you want to buy. And it tell you whether it's injection, whether it's tablet. You see all the details here. What this got to do with PSM? PSM is us. Maybe some people are here, the pharmacists, or some people are here, the doctor, but we are not medical practitioners. But what all this EML got to do with us? We have to play our part. If a clinician, pharmacist, health practitioner, professional want to compare, or even just to know what's the different medicine are available for a particular condition, the ATC help them to find it. In the main use of PSM is help to identify alternative. Increasingly, global drug shortage program require reporting by the ATC to evaluate seriousness of situation. An example would be, are you out of stock of amoxicillin or the beta last month, inhibitor, or so alternative? So it depends. The ATC help, or maybe there could be another cure for malaria, and you already know this medicine. So the ATC is the one there to help us evaluate the situation of medicine. And ATC is highly connected to PSM. Of course, we're all PSM practitioners here today. These are all statistics to show. You go through them, like we're talking about the levels. These are the statistics to show this from 2012 to 2018. That's maybe 3 years ago. What works? Simply implementation. That's our key goal here today. How can we implement our essential medicine list? The NEMP appears to be effective transformation operation mechanism for primary healthcare institutions. The improvement of mechanism for government investment. That's where you need to explain. That's where you need to advocate. If you don't explain, government will invest into the health sector and the health pricing system. So in conclusion, the MEP, China are instrumental to aim of providing basic healthcare services to every citizen. Other countries does that at the developed country. But what's about the undeveloped one, the developing country? So we have to look at that. Our main goal here today is to implement our essential drugs list. We need to get government to invest into medicine. In order for them to invest, we need to advocate, we need to explain. Then look at our recipe for success. Developing and implementing the EML. Multidisciplinary MNL committee. Let's form a committee. It should be what? Participatory, transparent, linked to what? Standard treatment guideline and formularies, right? We should also look at clarity on the purpose of the EMS, legal and administrative authority. Clear. We shouldn't go on the side, we shouldn't go under the dark world. No, let's make it clear to our authority. Official product launch. If you come over listing, you come over new drugs, let the public know that there's a new drugs is being added to your EML. Initial and reinforcement, orientation, and training. You have to train people on the use of new drugs, because somebody could say, I'm used to administering this drug. I'm not used to administering these other drugs that you just brought. So you need to what? Train. Regular update. Regular update. They didn't say one update, the regular update. because every day new disease comes, there should be a new treatment for that disease. Then we also have monitoring of the usage. I know you will participate in another express session that will talk about drugs use, and you will understand when we say monitoring the usage. That is the monitoring of the drugs on your essential medicine list. Getting closer to our ending, we talk about summary. The essential medicine concept was established more than 40 years ago. But guess what? We still got it on the paper. We're not practicing it. Nearly all countries have adapted them, but there's still a little implementation. We need to implement our EML. They are proven to work. What a vast body of evidence. WHO keep in model essential medicine list up to date. They do. It's model of essential medicine list right now, with revision every 2 years. Maybe somebody will ask the question, or maybe I ask the question. What do you know about EML? Is it being reviewed every year, or it's been reviewed every 2 years, or every 3 years? You tell me. But few countries have updated their list in their national list in the last 5 years. Well, I can't tell you what Liberia. I'm going to ask that question to Liberia. When the last time our EML was updated, there will be opposition from pharmaceutical industry and others who seek to promote their own agenda and interests, often using misinformation and distraction of some of the negative effect of the EML. Somebody will say the EML is becoming monopolized, so we need to leave the EML. So you need to be ready to justify, to prove that this list is essential. You hear that? They say what? Pharmaceutical companies will come and say, oh, because I'm producing these drugs, it's not on your EML list. He will find ways to bring bad information to the authority just so he can sell a drug. The word we're using today, be prepared to advocate. If you don't advocate, nobody is going to answer questions. You're not going to have an investment into your something. What can PSM do? Understand the importance and roles of the essential medicine concept. We as logistician, supply chain practitioner, we have to understand the concept of what? EML. If we do not follow essential medicine, our supply can never work effectively. Advocate, explain. It is not enough that you know, you have to be able to explain the need and benefit to order. I come from a very small country, undeveloped country, but I do my best so that the people in rural Liberia can benefit from basic health services. Thank you. We move to our second question and answer session. I see the chat room is filled. I think we have
I think the first question there is from Felix. Do you want to take it some more, or should I?
take the one for Felix that you can see right now.
Okay. So what is the area of application for medicine approved by EML and those approved by the NRA? Okay. So the National Regulatory Authority is for all medicines used in the country. Their concern is that they are safe, not that they are effective. They are safe to use. So they will license lots of multivitamin syrups. They're perfectly safe. Do they have any beneficial effect? Not much. So the essential medicine list is for medicines which are known to be effective and needed for the majority of people in the country. So the fundamental difference is between effective and safe. NRA is about safety. EML is about effective. That's the basic difference. Why don't some manufacturing companies specify the pharmacopoeia on the labeling? Because it doesn't conform to the pharmacopoeia, is the simple answer. Some new medicines are too new to be in the pharmacopoeia. WHO has a special system for that, which we'll explain in the next module about it, called the International Pharmacopoeia and the Monograph series. But basically, if it doesn't state, it doesn't meet that standard. Okay. Then we have from Patrick Capusula.
Yeah.
Can the country's economic status have an impact on the number of medicines in the EML? Yes, Sumo, do you want to give the example of Liberia?
So yes, definitely, Andy, I've answered that. Like that's a very good question. It sounds funny, but I can tell you, for developing country, my country is a highly donor supported country. So definitely your answer will be yes. The economic situation or start of a country can have a huge impact on the essential medicine list. I've given you an example. In the last 6 months, Liberia did not have what we call the BCG vaccine for kids. I think that's the vaccine that they give to kids so they shouldn't have tuberculosis. We have to go run into donor. That have a huge impact on our economy because of financial constraint. So yes, the country economic status have a serious impact on the essential medicine list.
Okay, so the answer is yes, and I'm going to add a but. So if we look at somewhere like the United Kingdom, they also have an essential medicine list. A country like Liberia spends about $15 per capita per person per year on medicines. The UK spends $800. That's a lot more, but their essential medicine list is not a lot bigger. They keep to the same essential medicine list. So yes, it's more, but it doesn't need to be massively more. Again, Canada, high-income country, has an essential medicine list. It's more, but it's not a lot more. The basic concept of essential medicine list is that less is more. That might sound strange. There are over 50,000 medicines in the world. You cannot hope to buy all of them. No country can. You cannot hope to store and distribute all of them. No country in the world can. So you have to decide which are the most important and then work from there. And that's the fundamental point of the essential medicine list. You only need about 400 medicines. That's all any country needs to meet the basic health needs. Okay, let's go on to the next question.
That's Aki. So are we saying that countries should place more emphasis on medicine vis-a-vis the rampant diseases within the country, seeing that all drugs should be on the list? Actually, Andy, you've answered that already. You can have all drugs on the essential medicine list. And you also made it clear from your questions that disease, rampant disease, maybe we could say most popular disease in the country. Definitely, that's why you need that medication to be on the essential medicine list. Like Liberia, I show we don't even have 100 on our essential medicine list. We have less than that.
Yeah.
Because you know the disease that occur, and it depends the season in your country as well. So Andy, you like to add up to that?
Yeah, okay. The point is that it's an evidence-based decision making. So we use this system called Quali and Dali. The concept is a bit complicated, but basically, how much trouble does this disease cause? How many people does it kill? How many people does it disable? And the higher the Quali score, the more important, that's the medicine we must have. So malaria kills thousands of people. We must have anti-malarials. But other diseases are very rare. Only 1 in 5,000 die from it. Sorry, we can't do that. We have to keep just to the focus on the evidence-based. Okay.
Yeah. Our next question comes from Nadira. Nadira, yes, you struck a good point. I think it's more of a statement than that of a question. You said the most important in EML is regular follow-up, training for the prescriber and pharmacist. In my opinion, that feature needs to enforce training as well as adapting. If you see in our summary, we mentioned that. We say yes, training. And I don't want us to limit it to only pharmacists, right? Because pharmacists are maybe making the request, you know, and then distributing. What's about somebody sitting as a minister who sit over the money, the Ministry of Finance, or somebody sitting at the National Drug Service, or somebody sitting at the regulatory authority? Everyone needs to get involved in order to make sure that we have an updated EML. So your points are all valid. Thank you, Nadara. And we come to something. Yes, we know about EML. How relevant is standard diagnostic list for laboratory commodities? Andy, you like to take this?
Yes, there's a WHO standard list for laboratory diagnostics. We fully support that. For the countries in Southern Africa, there's also an agreement among all the countries in the SADC region to keep the standardized diagnostics. There's also a list for medical equipment to standardize the medical equipment. So today we're talking EML, but there are lists for all parts of commodities. So therefore, lab diagnostics, both central laboratory and at point of care diagnostic tests, and for medical equipment.
Thank you, Andy. We have Emmanuel. After finishing your course offer, like procurement and supply chain management, do you have NGO or any alliance partners so that one can do practice there? I'm from Malawi. Andy, can you answer that?
We'll see. Try and find a placement for you, but we can't promise. But we'll see what we can do.
So Emmanuel, just to add up, I'm a graduate of Empowerment. I can tell you, doing this course, you're going to add more value when it comes to your career, because you're doing this course who highly connected to places like UNICEF. UNICEF is taking care of vaccine. You're going to understand how to store drugs, how to procure drugs, and UNICEF does that. So get ready to look outside bigger organization. It's going to build you up. It's going to boost your career. I can tell you that. And you should also understand that you're now part of a family. There's a full network. When you become alumni, you have colleagues, former students from around the world that you can get connected to.
Okay, I see Patrick Kapusala, you've got your hand up. Do you wish to speak? Please unmute and speak.
Yeah, I've got a question on the DALI and the GALI calculations. So you said this is one of the tools which we can use to bring an evidence whether to include a drug in the essential medicine list or not. My question is, yeah, so should we do those calculations for each and every medicine, or we can just have an assumption?
DALI most commonly would be used for new medicines when you want to add a medicine to the essential medicine list. You will ask, what is its DALI? Yeah.
Yes.
Let me give you an example. I can save your life. I've got to cut off your arm. It's going to cost $1,000. Is that worth doing? And most people would say, yes, I can still have a good life with only one arm. Now, to save your life, I've got to cut off 2 arms and 2 legs, and it's going to cost $10,000. Is that worth doing? Because your quality of life after this will not be very good. And DALI seeks to bring that kind of economic calculation to the quality of life. So anti-malaria medicines are very cheap, about $4. It's a short treatment and you're perfectly normal afterwards. That's really cost effective. It's really worth doing. Yeah. Insulin treatment is expensive and you need it every day for the rest of your life. Is that cost effective? That's the kind of calculation that DALI brings. We as PSM don't make the decisions. All we do is be aware of the evidence that's used to make the decisions.
Yeah, so I think I can have an addition to my question. In this postgraduate diploma course, do we have a certain chapter where you shed more light on the DALI and the quality calculations?
Yes,
Yes.
we do talk more
Yes.
about DALIs. Go ahead, Sumo. Yep.
Yes, I say yes.
Okay, but let's understand, DALIs are very complicated. The WHO training course is 2 weeks full time on DALIs, but we don't need to do the calculations. We just take the number from WHO. Yep. And look which is top of the list. Top of the list is usually malaria. Yep. And move down the list and select from there. But we do explain more about it in the course.
All right, thank you so much, Prof.
I see we've got one more from Felix, the session on monograph pharmacopoeia. Okay, in the course we'll explain about quality standards. Of course, many of you will know about the pharmacopoeia standards. United States pharmacopoeia, British pharmacopoeia, European pharmacopoeia. For new medicines, which might not be in the pharmacopoeia yet, WHO has a system called monographs, where they set the standard for the medicine before it comes in the pharmacopoeia. This will be explained in the course. Sumo, you may have encountered the monograph on some of the antiretroviral medicines, yeah? Okay. So some of the new antiretrovirals are too new to be in the pharmacopoeia. WHO will set the standard using a monograph and the international pharmacopoeia.
Yes, we did some adjustment to the slide. So,
All right, okay.
yeah. So is there any other questions? So if we don't have no other question, we come to the end. And then, like I mentioned at the beginning, you will have copy of the slide. It will be sent by our darling Priya. She will share the slide with each participant. I see we're like 51 here today. Thank you for your time. We managed within our 1 hour, 20 minutes. I think we were on time. Thank you very much. We appreciate it. Oh, I see 2 more questions coming. Oh, somebody saying thank you. Okay, thank you, Prof. That answered my question. Yes, we will share the slide. Definitely, we'll share the slide. Thanks, everyone. We appreciate your time. Thank you, Prof, for all the expert advice you've given. We appreciate it so much. Priya, over to you.
Okay, thank you so much, Sumo, and especially Andy sir, for this excellent expert session on module 2. And I would also request you all to please share our social media pages that I have already shared with you on your chats. Also, the slides and the recording of the session will be updated to you soon. Okay, and if you have any further questions related to the topic, so you are feel free to email me. I will forward it to the concerned person. That's it from my end. Prof, your feedback. Thank you.
Okay, well, I'll just say thanks to all, particularly to Sumo, for an excellent presentation. Really well done. I can see I can retire now. I'm not needed, and we can let the new generation take over. I think you're muted there somewhere, but okay. So
Yeah,
thank you very
I
much.
was saying we always need you in the back for backup.
Okay, many thanks to all for being with us today. We wish you well. Good night, good afternoon, good morning, wherever you are in the world. And we hope to see you again soon on the next expert session. Bye for now.
Bye. Bye, everyone. Bye, Priya.
Okay, thank you, Sumo. Thank you so
Thank
much.
you.
Thank you so much,
Bye.
sir.
Bye to everyone.
Goodbye and thank you.
I meet you in the next expert session, which will be next month. So be ready for it. Thank you.
Thank you.
Bye-bye. Thank you so much.